Olá, pessoal. Boa noite. Hoje vamos ter aí nossa aula aberta inaugural com a palestra do professor Dr. Peter Sturmy. Meu nome é Renata Cambraia, eu sou coordenadora dos cursos de formação e pós-graduação em Análise Comportamental Clínica do IBAC. Hoje a gente está tendo nossa primeira aula do semestre e a gente preparou essa aula especial com o nosso professor convidado internacional e resolvemos que queríamos também compartilhar, e deixar essa aula disponível para vocês no YouTube, para poder assistir ao vivo, para poder fazer perguntas, tirar dúvidas com o professor, e essa aula vai ficar gravada e vai ficar disponível na página do IBAC, que chama Eventos IBAC, página do IBAC no YouTube. A nossa... eu vou... primeiro, a gente vai começar com uma apresentação que está com áudio em inglês e legendas em português. E aí, mais tarde, o professor vai entrar para ter esse momento ao vivo para responder perguntas de vocês, tá? Então, o pessoal que estiver assistindo aí pelo YouTube, enviem questões, perguntas, dúvidas, comentários pelo chat, que a nossa assistente Ellen, que está aí, acabou de se apresentar, eu imagino, Então, bem-vindos aí. Raquel deu um alô também para a gente no chat do YouTube, nossa coordenadora, nossa diretora acadêmico-pedagógica, E a Ellen está aí na assistência do chat, se vocês tiverem dúvidas também sobre esse evento, o funcionamento, lembrar vocês de colocarem as perguntas no chat para interagirem com a gente, interagirem com o professor, certo? E aí, depois desse momento da apresentação em inglês com as legendas em português, o professor vai estar aqui ao vivo para que a gente leia algumas perguntas para ele responder para vocês. E temos também aqui na sala, no Zoom, os nossos novos alunos, Então, a gente convidou todos os alunos do primeiro módulo da formação em Análise Comportamental Clínica e as duas turmas que a gente tem da pós-graduação em Análise Comportamental Clínica, turma de quarta-feira à noite, e temos uma turma de sábado de manhã que a gente convidou para estar aqui com a gente hoje também. E aí, convido também os nossos alunos aí já matriculados na pós, que possam também enviar perguntas no chat, e também quando o professor estiver aí presente, vocês possam também levantar a mãozinha aí no Zoom e podem ligar o áudio para fazer as perguntas de vocês, tá certo? Então, um momento aí para a gente poder ter uma troca bem bacana com o nosso professor internacional da pós-graduação em Análise Comportamental Clínica. Que mais? Recadinhos. Acho que é isso, gente? Vou apresentar o professor e um recadinho importante. Hoje abriram as inscrições para o primeiro Encontro Nacional de Análise Comportamental Clínica. Vai ser presencialmente aqui em Brasília, 5, 6 e 7 de outubro. Acessem o site do IBAC para ver mais informações, as inscrições. A gente vai ter, a gente está com lote promocional aí, os primeiros 15 inscritos de cada categoria vai pagar um valor bem baixinho, e depois disso a gente vai ter diferentes lotes, então corram para se inscrever no primeiro Encontro Nacional de Análise Comportamental Clínica, que vai acontecer presencialmente aqui em Brasília, a sede do IBAC. Ok? Também vamos aceitar submissões de trabalhos, então confiram lá no site ibac.com.br/ENAC, ENACC, para quem quiser propor uma apresentação no evento de painel, de mesa redonda, de apresentações orais. estamos aí com submissões abertas. Então, deem uma espiada lá também, que a gente adoraria que vocês, né, venham conhecer a gente, né? E a gente possa ter um momento presencial também, né? A gente tem tantos eventos online, mas a gente tem tentado cada vez mais proporcionar algumas atividades presenciais para que a gente possa se conhecer melhor. Vamos lá. Então, parar de enrolar aqui, né? Vamos começar. Eu sei que vocês querem ver a apresentação. Então, o Dr. Peter Sturmy, ele é professor de psicologia na graduação e também no programa de doutorado da City University de Nova York, nos Estados Unidos, e ele também é professor na University College, na Inglaterra. Ele é doutor em psicologia pela Universidade de Liverpool, onde ele teve treinamento em psicologia clínica. Ele é autor de mais de 100 artigos, principalmente na área de avaliação e tratamento de pessoas com transtorno do espectro autista e outras neurodivergências. Ele também trabalha com treinamento em análise funcional e formulação de casos, publicando os livros Análise Funcional na Psicologia Clínica, em 1996, e também Intervenção e Formulação Comportamental de Casos, uma abordagem análise comportamental, foi publicado em 2008. Então, o tema de hoje é formulação de casos, uma introdução. Né? Então, é uma fala introdutória para a gente, né, entender melhor sobre como, né, que seria essa formulação de casos e como a gente tem diversas possibilidades aí. Então, agora, vou compartilhar aqui com vocês. Okay. Yeah, we're all set. You can start whenever you're ready.
Okay, I'd like to welcome everyone today to this presentation entitled Case Formulation and Introduction. I'd like to thank Professor Cambrea for inviting me. It's always fun to work with my colleagues around the world, especially in Brazil. Today, I'm going to talk about case formulation, which is a core clinical skill. And many different kinds of mental health professionals, psychologists, clinical social workers, psychiatrists, and so on, view this as a core skill. So today, we're going to look at the definition of what case formulation is, and look at some methods that we can use to make a case formulation, and look at some examples. And I'm going to ask the key question, does it make a difference? Does it improve outcomes in treatment? So that's a brief overview that we're going to look at today. So let's begin by thinking about what a case formulation is. Behaviorists often use the expression functional analysis or causal analysis, which is very similar to what we look at in behavioral case formulations. If you Google functional analysis, you don't find things about psychology. You find things about mathematics. And you'll find journals in mathematics called functional analysis. A function is a shape of a curve. The little graphs at the bottom are functional analyses. The one on the left is from metallurgy, and the ones on the right are from basic behavioral research done with pigeons. The curves look rather similar. And we sometimes use the term functional analysis to describe how to predict behavior based on the independent variable. When we look at the term functional analysis, it's used all over the place. It's used for eating disorders, physical disorders like chronic pain, autism, depression, arson. There are lots of examples. And we sometimes distinguish between experimental versus non-experimental versions of functional analysis. We sometimes also use the term functional behavioral assessment, where we do a descriptive analysis, where we don't manipulate the environment, but we just make an educated guess as to what the causes of a behavior, such as a clinical problem, might be. So that's a behavioral approach to case formulation. It overlaps with the term functional analysis or functional assessment. In the US, the term functional behavior assessment is actually enshrined in the law. Federal law here requires school districts to do something like a case formulation for children whose behavioral issues interfere with their education. State laws tend to be prescriptive as to what must go into the formulation and when to do it, but they're not too clear as to how to use a case formulation or a functional behavior assessment. Some of the professional standards, like those from behavior analysis, are much more explicit and detailed, as we will see. So in the United States, or if you're a behavior analyst elsewhere, if you don't do a functional behavior assessment or a behavioral version of a case formulation, you might get into trouble because you didn't do the things that are required of a professional. Here's an example of very explicit standards for functional behavior assessments. These are from the New York State Education Department. So they only apply to New York and they only apply to the public school system. But the case description or the functional behavior assessment has to have 6 things. And this law tells you what they are. So you must have a baseline of the problem behavior, and you must specify frequency, duration, intensity, or latency. You must have some commentary about the differences across different activities, settings, and people, and times of day. You must specify the triggers for the problem, the antecedents, and you must identify the reinforcing consequences for the target behavior. You must also specify the replacement behaviors, the appropriate behaviors you want to encourage and teach, and specify the students' preferences for reinforcement. So these standards are very prescriptive. Now notice up to now, I've been using the term functional behavior assessment or functional analysis. Those terms are narrow and more specific to applied behavior analysis, but they're very influential in behavioral approaches to case formulation. But there's a much broader field of clinical case formulation. And here are some examples of definitions of what a case formulation is. One of the most prolific publishers in this area is a professor called Tracy Eales. He's had a very good handbook, which is in its 3rd or 4th edition. And he described that a case formulation is a hypothesis about the causes, the precipitants, and the maintaining influences of a person's psychological, interpersonal, and behavioral problems. So notice that in this definition, it's not specific to any kind of theory. It does list that it's a hypothesis, and it's got to mention causes, precipitants, and maintaining influences. So there are 3 things that must be in there. And it could address psychological, interpersonal, and behavioral problems. But it's rather broad. But I guess if we're using this to grade formulations or teach people to write formulations, you teach them to write what the causes are, what the precipitants are, and what the maintaining influences are. If you didn't have all 3 things, it wouldn't be an adequate formulation. A little later, a British worker in cognitive behavior therapy described a case formulation as a process whereby therapists and client work collaboratively, first to describe and then to explain the issues a client presents in therapy. Its primary function is to guide therapy in order to relieve client distress and build client resilience. So notice in the first sentence, it describes that this is a process between the therapist and the client, and it says that the work is collaborative. It's not something that the therapist does to the client, it's something that they do together. And it must do two things. It has to describe the clinical presentation, and it must explain the issues. And then the therapist and the client must use that to guide therapy, and there should be two outcomes: relief of distress and building client resilience, has implications there for the evaluations of case formulation. And finally, other people from Britain doing cognitive behavior therapy said that a case formulation is the elicitation of appropriate information and the application and integration of a body of theoretical psychological theory to a specific clinical problem in order to understand the origins, development, and maintenance of the problem. So notice that each of these three definitions actually has slightly different content. The first one has those three things: causes, precipitants, and maintaining variables. The second one says it must guide therapy, relieve distress, and build resilience. And the third one says it must understand the origins, development, and maintenance of the problem. So although these definitions are similar and overlapping, they do have slightly different kinds of emphases as to both what goes into a formulation and the purpose of the formulation and what it should do. So why do we do this? Usually, if you do a class in psychopathology or mental health, very early on, people often focus on diagnosis. Surely, diagnosis should guide treatment. Let's face it, we prescribe antidepressants for people with depression, not for people with schizophrenia. And we give people with schizophrenia antipsychotic medication, not antidepressants. Psychologists do the same. They have groups for behavioral activation for depression and for social skills and relapse prevention and monitoring for schizophrenia. Both psychiatry and some forms of clinical psychology use diagnosis to predict the best treatment. When we say a medication is an antidepressant, or we say a treatment is for depression, we're saying that the diagnosis predicts the treatment that's going to work and the treatments that's not going to work. But everybody knows that there's much more to it than that. The outcomes of diagnostic-based treatments are very variable. Cognitive behavior therapy for depression is often quite effective for around a third to maybe a half of a group of people. A couple of people won't respond, and maybe occasionally somebody gets worse, and they get worse because of the treatment. So what good is diagnosis to predict treatment? And you see this in clinical practice, where people start to make up diagnoses to justify new treatments. The person that didn't respond to an antidepressant gets a diagnosis of general anxiety disorder, then gets an anxiolytic medication. But what about people who have multiple diagnoses? What if the person has a major depression, an anxiety disorder, and abuses alcohol? Where do we start? What diagnosis should we pick to guide treatment, whether it's psychological or pharmacological? But what if the main problem isn't any of those three things? What if the problem is that the person is violent to their spouse? Do these three diagnoses tell us what treatment to use that relates to aggression? I don't think so. And what about people who have unique fears? What if I fear other people vomiting? Where's the diagnosis in that? What can I use to guide treatment? What if my client is scared of buttons? Where are the diagnostic-based treatments for that? They don't exist. So these are some of the rationales that we use to justify case formulation, to individualize treatment to each individual situation. So here are some of the goals of case formulation. The first big one is to predict the treatments that are most effective and the treatments that we should avoid. People have a good idea of the kinds of treatments they're going to do. So if you're going to do a case formulation, it should do better than the standard treatment. And later on, we'll see some evidence that at least sometimes that happens. But a formulation should be concise, it should be parsimonious, but also comprehensive. So it has to be all the information you need to predict the individual's best treatment, but no more. And it's not just a long description of the case or a long history. It's just an abstraction of the key features of the case to predict the best treatment. And Eels and Lombard say you have to balance description and explanation, and it should use evidence-based practices. There are now tens of books on case formulation, and literature's going back to the 1950s. And there are different approaches, some of which are theory specific. So there's a huge literature on cognitive behavior therapy approaches to case formulation. If you go into Google, you'll get tons of books, especially related to depression, anxiety, and maybe substance abuse as well, and personality disorders. But you'll also find books on psychodynamic formulation. You'll see books by Turcat, Wolpe, myself, and parts of Skinner's books address behavioral approaches to case formulation. And there are atheoretical or integrative and pan-theoretical approaches from people like Weira Sakira. So there are lots of different approaches to case formulation, which is why I think Eels avoids theory-specific features of case formulation. Looking at this as a behavior analyst and thinking about how to do behavioral case formulations, I go back to the basic and I look at Skinner's book, Science and Human Behavior, now more than 70 years old. And I look at the chapters on psychopathology. And Skinner has a theory of psychopathology that can inform case formulation. Skinner says that psychopathology comes from society's efforts to restrict behavior reinforced by primary reinforcers. The group that we're in, our religion, our parents, and the education system stop us grabbing things, grabbing cookies, and being impulsive. And it does it quite effectively, but it does it primarily through positive punishment. We reach for the cookie and grandma slaps our hand. We wriggle around in church and our parents give us the look and the gesture and tell us, wait till you get home, you're going to be in trouble. This works. People straighten up in church and they don't steal cookies, at least in front of grandma and mom and dad in church. But there are problems. People learn to escape. They'll say, I didn't take the cookie, I was just looking at it to see if it really was a cookie. I was going to put it back in the jar. People will revolt. They'll say, I don't like your rotten cookies, screw them. And then they sneak them later on. Oh, they just act passively. And I say, what did you say? Oh, I didn't hear you say don't take the cookie. Did you mean this cookie? I didn't understand. So we have all kinds of avoidant behavior that's a problem. And if we have too much of a history of positive punishment, we have undesirable emotional byproducts. When we see grandma sitting next to the cookie jar, we get scared. We straighten up and our hearts race and we start to sweat and we become fearful and anxious. When she says, be careful, sometimes we'll get angry and we'll show behavioral excesses. Or sometimes, if the history of punishment is too great, we'll look like we're depressed. We'll stop behaving at all in the presence of environments where we have a history of punishment. Sometimes things that predict punishment, like warning signals or our evil math teacher or the horrible high school where we're punished, will cause us to freeze. We won't be able to say anything. We won't be able to move because of the side effects of history of punishment. And to get over that, we may drink alcohol, take drugs to reduce anxiety, legal and illegal, or we may avoid punishing situations by being too vigorous, by talking constantly, or being too self-restrained. We'll stop ourselves moving to avoid punishment in the future. This is a good guideline of what to look for in clinical cases. Skinner gives an example. He takes an example of a transition. Somebody who graduates from college and now is going to work. And suddenly this young man finds out that all the things that worked in college suddenly are useless in his new job. So if you look at cases of depression, they often look like this because there's a transition where someone goes from contingencies of reinforcement to extinction in a new environment. In everyday language, we say he's unconfident, he's insecure, unsure of himself. Skinner says, well, it's because he's not reinforced very often and his behavior is under extinction. We say he feels frustrated. And Skinner says extinction is accompanied by emotional responses. He says uneasy and anxious. Skinner says, well, he's unable to avoid the punishment. He is lousy at his new job and he gets reprimanded or disapproved of, and so he becomes anxious in the presence of new contingents of punishment. He goes to work and he just doesn't feel any pride in what he does. He doesn't know what he's doing. He doesn't know what he's supposed to do. Skinner says his behavior is rarely reinforced. And we say he's guilty and ashamed in everyday language. You say, well, in the past, he's been punished for being idle. And now he doesn't know what to do in his new job. And that history of punishment evokes emotions like guilt and shame. Again, this can be a useful framework for some clinical cases. You could take this information and write this little table into a clinical case formulation using behavior analytic ideas. So Skinner uses a narrative description based on behavioral concepts. He doesn't tell you what to do exactly. He doesn't prescribe a treatment. But what he does recommend, rather generically, is the use of behavioral self-management. That is, arranging your own environment to promote adaptive behavior and minimize the likelihood of problem behavior. He doesn't say exactly what those things are, but in the video clip that I referenced in slide 13, you see Skinner working with therapists and a child with emotional and behavior problems, where the child is taught to use self-recording and timing themselves using a stopwatch to manage their own behavior. The child is taught to emit the controlling responses of setting a stopwatch, writing goals, and self-recording, to change the controlled response of emotional outbursts and increase cooperative behavior. And you'll find it fun to look at that video clip on YouTube. It's very, very instructive. It's quite old, but very handy. People have actually done true functional analyses of psychopathology. There aren't many of them, but they're there. In this old paper, in a token economy, Reisinger used tokens to reinforce and extinguish smiling and crying. Crying was viewed as operant depressed behavior. In the baseline, sessions 1 to 2, you see that the individual does not smile and cries many times during each session. In sessions 3 to 8, you see that Reisinger uses tokens for smiling. It doesn't address crying directly. But by differential reinforcement of smiling, the probability of crying behavior, the behavioral index of depression, decreases to close to 0 at weeks 7 and 8. In weeks 9 and 10, it reverses, thereby showing experimental control of depressed behavior and non-depressed behavior. There's another reversal, and so on. So here we have an experimental functional analysis of depressed behavior. It is possible to do this. Later on, Jones and Pat Fryman conducted an experimental analysis of phobic behavior. This was a teenager in a school with a phobia of insects, or bugs, as we say in the United States. In sessions 1 through 9, we see a multi-element design where different conditions were run in each block of 3 conditions. In the no bugs condition, the teacher said there aren't any bugs. In the say bugs condition, the teacher said there might be some bugs in the classroom today. And in the bugs condition, there were actual bugs in the classroom. They measured the adaptive behavior, the number of math calculations that the individual did. And they showed that in the no bugs condition, the individual showed lots of adaptive behavior. In the bugs condition, they were only able to do half as many math problems. Anxiety evoked by the insects interfered with adaptive behavior. Other approaches by Wolpe used experimental, non-experimental methods using interviews with the client and significant others. It's a kind of detective work. I'm going to give an example of personality disorders because you think that's something that is so diffuse and it would be hard to pin down. But Wolpe and Turcat point out that in fact there are discrete target behaviors like avoidance of criticism, stomach pain, thinking something awful is going to happen. And there are specific situations like the presence of supervisors or public speaking. And so you can break down this diffuse personality into target behaviors, situations, and its history in early development. So they present an example of antisocial personality disorder. And this is a 28-year-old man referred because of back problems. And he was asking for more pain medication. And there's some hints of depression. He's a smart, verbally facile individual who talks freely and is cooperative. He's a little avoidant about exactly what his personal goals are and something wrong with his marriage and concerned about his injury, but a little avoidant about some of the main problems. But he cooperates with self-monitoring and a battery of psychological tests that shows he's a highly intelligent, depressed, highly psychopathic, impulsive, bored individual. His wife reports that when he was in the military, he did better, and with friends, he reported less pain. But in unstructured environments and with a lack of structured activities, he showed more problematic behavior. Turcat and Wolpe break this down into 4 groups of problem behaviors: alcohol and drug dependence and promiscuity, unhappiness, boredom, and lack of exercise, poor judgment, impulse control, and poor delay of gratification, and being overly demanding and childish with his family. This is what antisocial personality is, 4 response classes. They conduct a descriptive analysis of the development of this case and describe how his father was a model for many of these behaviors, including violence and drinking, how his mother had standards for behavior but did not enforce them, and his peers encouraged all kinds of acting out. And as somebody who was easily bored, he readily got into thrill-seeking, drug use, and so on. And many things like being in the military provided the missing thrills in his life. And he was able to use his intelligence and charm to avoid responsibility for many of his problems until he was pulled over or drinking under the influence of drugs and financial problems related to that. And suddenly, his ability to control his problems was falling apart, and he realized he needed help. Initially asked for pain medication, but kind of sort of knew he needed much bigger help than that. The actual formulation is in slide 21 that says that cycles of acting out result in negative outcomes of depression that provoke more acting out to get more thrill-seeking behavior. He learned this behavior from his family members and peers, but he never learned to manage his own behavior. He never had the repertoire of self-control that Skinner talks about. And he settled for a boring but controllable marriage where he could seek out thrills in the Marines and elsewhere. But by the time he's in his mid-20s, he's stuck in a problem situation after leaving the Marines. And he focuses on back pain and seeking medication as a way to do that. So we can have specific goals now: reducing alcohol and drug use, addressing depressed thoughts and behavior, and trying to promote the positive aspects of his life, either, for example, improving self-discipline, improving his marriage, or negotiating a divorce, or getting on with life's chores by having clear occupational and educational goals with immediate costs in terms of effort, but long-term benefits in terms of financial and personal rewards. So, when we look at this, we can see how behavioral formulation of a complex case can boil down a rather diffuse problem into a group of target behaviors that we can address in ways that are systematic. So formulations are done to predict treatment that are better than you otherwise do. They're there to integrate history and development with the presenting problems, and to analyze complex cases into something that we can manage and use to guide treatment. And they're done from all kinds of theoretical perspectives. The last section today is going to answer the question, is it worthwhile? Does it make a difference? I'm going to present only one study to show where it does make a difference. And this is a study by Gaderi from Finland, published some 20 years ago. And interestingly, he worked with a clinical population of individuals with bulimia. I think they're all outpatients. And these 50 patients were randomized to a standard effective treatment, standardized, manualized cognitive behavior therapy. This is a very effective treatment and has a good evidence base from multiple randomized controlled trials. Gaderi compared that to function-based individualized treatment that combined cognitive behavior therapy with individualization based on the case formulation. And so the cognitive behavior therapy strategies were guided by his version of case formulation that he calls logical functional analysis. He commented, sometimes the case formulation is very similar, the treatment based on case formulation was very similar to standard cognitive behavior therapy where that was indicated. But in many cases, individual components were added or modified to address rule-governed behavior, use of acceptance and commitment therapy, strategies to address interpersonal relationships, strategies for trauma, abusive relationship, or social isolation. So the treatment group for the case formulation got more varied, individualized treatments. As you'd expect, both groups improved a great deal, and they all did better than baseline. And the effects were maintained at 6-month follow-up. That's very impressive. However, the function-based treatment was superior to the standard cognitive behavior therapy. Slide 28 shows the data pre-treatment, post-treatment, and the 6-month follow-up. The purple line is for the standard cognitive behavior therapy group, and the blue line is for the function-based treatment. And the dependent variable on the y-axis is the number of weeks with no objective bulimic episodes, so no weeks with no vomiting. In pre-treatment, both groups are the same. They rarely go for more than a week without some episodes of bulimia. Post-treatment, both groups improve considerably, but the difference between the two groups is statistically significant, and I will show you, I think, clinically significant as well. So post-treatment, the standard cognitive behavior therapy group, on average, goes 6 weeks without any episodes of vomiting, whereas in contrast, the function-based group go 10 weeks without any episodes of vomiting. So those differences are large and statistically significant. They looked at responders and non-responders, and they had an objective definition of non-responders to treatment. And out of the 51 participants, 8 of them were from the standardized cognitive behavior therapy group, but only 2 were from the individualized functional analysis based group. So we have 8 out of 25 people, or a large percentage, nearly a third, who are non-responders in the standard group, but only 2 non-responders in the individualized group, so 2 out of 25. So it's 10% versus 40% non-responders. Those differences, I think, are both large and meaningful. You'll notice in the case of honesty that the differences at 6 months are not so great, and the differences are not statistically significant. I think we can still agree that the large differences at post-treatment are worth having, and this is the evidence that sometimes individualized clinical treatment is worth the effort of doing a clinical case formulation. So to summarize today's brief presentation, we can say that case formulation is an established professional competence. Many different clinical professionals should have this competence, and it can be done from many different theoretical formulations, from behavioral, cognitive behavioral, psychodynamic, or atheoretical perspectives. And it is useful, if it's done well, in predicting effective and ineffective treatments. The outcomes, in fact, are quite mixed. We saw an example of a positive outcome today from Garderi's treatment study of bulimia. But there are at least 2 studies for anxiety disorders where they compare exposure and response prevention versus case formulation-based treatment and find no difference between the 2 treatments. Or in fact, in one study, they find that exposure therapy was superior, better than case formulation treatment, suggesting that individualization is actually harmful. I might argue that maybe the people doing the formulations were not very good at it. Or perhaps it's just that exposure therapy for anxiety disorders is just extremely effective, and it's kind of hard to do better than that very effective treatment. Maybe there's no need for case formulation in that situation, unless the standardized, highly effective treatment isn't needed. One thing that's missing from the literature is work on training clinicians and staff members how to do formulations and how to use them, and how to work with clients to co-produce formulations together. I think future research should do that, and I hope to see that soon. I'll take a break there, and Renata, maybe we'll stop recording at this point.
Olá! Obrigada, gente. Vamos lá, o professor já está aqui na sala. Hi, Peter.
Hello.
Did you click on English? Okay, thanks.
I think I did.
Tá. Ele colocou? Tá em português, né? Quer dizer, tá traduzindo, né? Quando eu falo
I'm trying to get to the menu. I can't see it very easily.
So you didn't hear me right now when I spoke in Portuguese?
I heard the Portuguese, yes.
Okay. So on the main menu, you have a little globe.
I'm trying to find, okay, so I've hit English on the main menu. So I can hear you in English.
Ok. Testando. Tá me ouvindo? Tá ouvindo a tradução?
Yes, I can hear you.
Ótimo.
Yes, I hear your translation, yes.
Great. Então, pessoal, vamos, né? A gente transmitiu aí essa apresentação gravada com legendas em português, até para facilitar, né? De disponibilizar nos 2 idiomas para vocês. Mas agora a gente vai ter essa sessão de perguntas e respostas ao vivo, então o professor, né, se disponibilizou a estar aqui, né, nesse horário que a gente tem aulas tão tarde aqui no Brasil. E o professor não está acostumado com isso, mas se dispôs a estar aqui hoje com nós, né? Estamos aqui na sala os alunos do curso de pós-graduação em Análise Comportamental Clínica, né? E também convidamos os alunos de formação para estarem aqui hoje ao vivo nessa aula, que é nossa primeira aula do semestre, né? Então, estamos começando o semestre e temos aqui os alunos que estão iniciando esse curso, né? Estão no primeiro semestre, tanto do curso da formação quanto do curso da pós-graduação, e estamos, né? Não queríamos desperdiçar essa oportunidade, então compartilhando, transmitindo também via YouTube aí para o pessoal que não faz parte do curso ou que não faz ainda. Então, o pessoal que tiver interesse, né, em fazer os cursos de formação e pós-graduação em Análise Comportamental Clínica do IBAC, eu já coloquei aí os links no chat do YouTube para vocês poderem acessar e ter mais informações, e qualquer coisa podem me mandar um e-mail também para a coordenação ACC, sem acento, né, e nem tio, coordenaçãoacc@ibac.com.br. Então, vamos começar, né? Pessoal que está no YouTube, vocês vão ouvir a versão com interpretação em português, e depois a gente vai disponibilizar o áudio original também para quem quiser ouvir, né, ou assistir depois a aula e ter a sessão de perguntas e respostas no áudio original. Pessoal que está aqui na sala, cliquem no globinho que eu estava pedindo para o professor clicar em inglês, cliquem em português, porque aí vocês ouvem a tradução para o português quando o professor estiver falando inglês, para poder ouvir a tradução, que hoje temos aqui o nosso Felipe, nosso intérprete, né, que já tem participado aí dos últimos eventos do IBAC. Temos uma pergunta que eu vou ler aqui, então, do professor, que foi enviado pelo pessoal ali do YouTube. Não entendi muito sobre tratamento padronizado. Isso quer dizer que nem sempre devemos fazer uma análise funcional para todos os casos?
Okay, it's a good question. I'd like to start off by thanking everybody coming to the presentation. It's late in the evening for everybody, and I understand many of you are working during the day and then coming to graduate school at night. So thank you for coming. I'd like to thank Professor Cambrea as well for all her work organizing this, and our very fluent and rapid translator, Felipe, as well. So thanks for everybody. The question of should you always do a formulation is an interesting one. Usually, the standards in clinical psychology training or in other mental health professionals would say that, yes, you should always do a formulation. And the idea is that you as a therapist should understand the case using professional and scientific ideas. But a good question is, when you are a busy clinician with lots of clients to see, and when you have a very effective treatment, for example, standardized exposure therapy for anxiety disorders, there's a cost to you and to your patient to do the formulation. When you do the formulation, you're delaying treatment. Now, perhaps it doesn't matter very much on many occasions. If you can get a basic idea of what is going on, let's say with a case of an anxiety disorder, in 1 or 2 appointments, there's not much delay. And it is possible that there is some individualization that comes from that. So, for example, if you take somebody with agoraphobia, you could treat that with a standard manualized treatment. Take them out on the bus, take them out on longer journeys, take them out to the mall, take them out to progressively more crowded places. That's very likely to be a very effective treatment. But I do wonder, you might ask, well, but what are you exposing them to? What are the conditioned stimuli that need to be habituated? One person might fear people staring at them. Another person might fear going down the escalators and being confused and worrying that they're going to fall. Another person might fear that they're going to vomit in public or scream when people look at them. I think, and I have no evidence for this, but I think it is useful to know that so that you can ensure that the clients are exposed to those conditioned stimuli during exposure therapy. Now, it may be that it happens anyway with a well-designed, standardized exposure therapy program. The chances are that you may well expose the person to that. But perhaps if you know what the relevant conditioned stimuli are, perhaps you can do a better job to make sure that that's the case. So I think the answer is professional standards would say, yes, you really have to do formulations all the time. But in some circumstances, you don't have to spend a lot of time doing that. Sometimes, I think in Britain, in the IAPT project, where people get standardized cognitive behavior therapy for mixed depression and anxiety, they kind of have a triage approach where while you're waiting, you get bibliotherapy or advice. Then you get group treatment, which may be quite effective. But then the clinical psychologists tend to step in for individualized formulation-based treatment for those people who don't respond to the standardized group therapy. Now, when you look at that, probably the bibliotherapy is not very effective, but it's not very expensive either. So the fact it might help some people a little bit while they're waiting for a group treatment is probably an okay thing. And reserving the formulation-based treatment for people who don't respond to the manualized treatment at the end, where treatment becomes expensive because it's based on individualized therapy, might be seen as a good use of resources, especially if you can have cheaper master's level therapists who've been trained to follow a 6-session manual for group cognitive behavior therapy, and they do help several people in the group, and they are quite effective. Plus, they're helping several people for one session as well. So that's, you know, that's a good use of resources. So reserving the expensive, more resource-intensive treatment for non-responders might be when more detailed formulation might come into place. What do you think of that answer?
Alguém quer comentar, gente? Eu posso comentar. So I thought the question was really a good one, because I was wondering the same thing. So you gave the example of exposure therapy, but recently I've been studying a lot of behavioral activation therapy. Yeah. And I've seen some suggestions of first do basic activation. If you identify that it's, you know, depression, begin with the basic model of behavior activation. And then if you realize that you're not getting good results, or you're not really progressing therapy, then do a functional analysis and then train specific repertoires like social skills or contingency management, and then think of different things you could add to the treatment based specifically on that case. Does that, I believe that goes in line with what you
it's a very similar example. But I wonder, you know, if you were doing individual therapy using behavioral activation, I think you should still be awake and paying attention and looking at the person and going, you know, they're awful shy and they're scared to ask someone to go do an activity with them. You know, they're scared of taking their kids to school. You know, why wait till the end of the behavioral activation sessions? I think if you're doing it therapy individually and you're thinking about formulations, you're probably going to be able to pick up on individual factors that might be very important.
I guess it would be more of a cost-benefit analysis.
Yes.
Oh, sorry, my connection isn't stable.
I can hear you fine.
Okay. Yeah, so I was thinking maybe it's more of a cost-benefit analysis, depends on the setting, on the context, if it makes sense to try and start offering some kind of treatment, especially if you have a lot of people, or a large wait list, versus just individual treatment. Someone comes to your private practice, and then you'll probably, you know, have time to actually maybe produce a better case formulation, more detailed, better functional analyses.
I think those differences are very important. So when I did clinical work in Britain in a National Health Service, there'd be 150 people waiting for treatment. I think over the last 30 years, it's gotten much worse. Wait times for people to be seen are months or sometimes years for adolescent disorders, eating disorders, and so on. What are you supposed to do for these people? If you have a, you know, perhaps not very flexible, not very sophisticated therapist, but who can do some things good enough, they can follow a manual and help some people. Why not? You know, so I think but in the United States, most people pay for treatment themselves. It's mostly private money or minimal coverage from health insurance. Maybe people get coverage for 6 sessions, you know, what do you do at the end of that? People pay for it out of their pocket. So I don't know what the situation is in Brazil, whether it's like public service or a mix of private and both.
We have all of those. So yeah, I mean, we do have public services, so it would be great if we had included in our public policies or in our public mental health policies to have these evidence-based treatments and have therapists trained in these, but
Yes.
I don't see training happening that way in Brazil, so it becomes a problem because you have therapists being trained in this super individualized training and a lot of different approaches in psychology, not just cognitive and behavioral. And then these professionals are going to work in these hospitals and other environments where in which these services are being offered, and we have huge wait lists and people are suffering, and they're not being trained to offer like quick, effective treatments. So that would actually be ideal in those cases. But we also have, I mean, I guess most of our students end up at least some of the time working with individual clients in their private practices or in clinics that are able to actually offer this more individualized treatments.
Yeah.
We have.
I'd be interested. I'd be interested in the students. Do the students have any more questions about formulation? I think I see 3 messages. Okay.
So Fernanda, yeah, that's what I was going to say right now. Fernanda, I'm going to read the question in Portuguese. Quando iniciamos a formulação de caso, é mais interessante iniciar pela queixa do paciente ou partir dos pontos que Skinner aborda, os níveis de seleção do comportamento, filogenético, ontogenético e cultural. E a Bruna disse que também gostaria de saber por onde começar essa formulação de caso.
Okay, that's a good practical question. I think at the beginning, when you're doing your first clinical interview, think about the motivation of the patient. They come to you, they've got a problem. You have all these degrees up on the wall, the signs and symbols that you have something to help their problem. You're there to relieve their suffering. That's why they're coming. That's the main reinforcer you have, is to help them with their discomfort of various kinds. So when you look at most semi-structured behavioral interviews, people usually start off with the main problem. And so they would start off by saying, tell me what brought you here. What are the main problems? And then using open-ended questions, what else is going on? Are there any other problems? Are there other things that worry you? So I think the usual answer is to try and get the problem list sorted out and put into a hierarchy of the main problems. So I think that's where most people doing behavioral case formulation would start. I think when you do that, and you've probably seen this before, very often your clients have a very rehearsed story. They've told their story to other people prior to coming to see you. And so they'll give you maybe a long history or something, a story they've told other people. Sometimes they will omit things which are quite important because they think it's not relevant. I can think of somebody who was having a lot of problems related to stress and anxiety at home. And she had this very rehearsed story about panicking over things at home. having to prepare meals for a string of her husband and children coming home throughout the day, her husband writing checks without telling her and having terrible financial problems. So she had plenty to worry about. And then at the end of this, I asked the question, are there any other things that are bothering you? And she said, well, it's not relevant, but I've got this problem with my feet and they really hurt. And so it's very hard for me to walk outside because my feet hurt all the time. I've got bunions. And I think that's when another problem came up, which is organizing meals for everybody from 4 o'clock in the afternoon till 9 o'clock at night. And she didn't think any of that was relevant, but she was on a schedule of positive punishment for walking. And so it's no surprise that she didn't go out and expose herself to fear-provoking stimuli, not only because she was scared, but also because it hurt. So if I hadn't asked you the question, what other problems do you have? Quite often people do have quite a list of other things going on. So I definitely ask those things as well. So the main answer to your question is typically people doing behavioral case formulation start with the main problem. It does show that you as the therapist are there to help with the main source of anxiety, the main source of discomfort or dis-ease for the person. And I think if you go off on tangents early on, it might suggest that you're not recognizing the main problem. Maybe later on you should do that for some people. So I'd start with the main problem. That's a good question. Thank you.
Thanks. We also have another question here from Roque. Quando eu penso em pesquisa clínica com tratamento baseado em formulação de caso, penso na dificuldade em realizar as pesquisas de maneira replicável. Acha possível que exista ou já existe algum tipo de protocolo para formulação de caso baseado em análises funcionais?
Okay, I didn't get that in English. I think I understood half of it. Are there standard protocols to follow?
Do you want me to read it again? I think I should read it again. Quando eu penso em pesquisa clínica com tratamento baseado em formulação de caso, penso na dificuldade em realizar as pesquisas de maneira replicável. Acha possível que exista
there are some examples of where the formulation is simplified into a small number of typologies. For example, there are some papers on school refusal for children and adolescents. And the typologies are basically, what are they avoiding? Are they avoiding academic work? Are they avoiding social punishment? Are they avoiding anxiety to do with travel? Or are they getting positive reinforcement from parental or teacher attention? And so the goal of the formulation is to slot each child into one of those 4 or 5 typologies. And then the treatment corresponds relatively tightly to the typology. So if the kid is avoiding difficult tasks, then the treatment is exposure to progressively longer and more difficult academic tasks at school, and that's done progressively. If the function is primarily positive reinforcement, let's say from parents who keep them at home, keep them safe, make sure they're not sick, give them laptops and nice meals and watch TV and text their friends all day long, then the treatment is contingency management based around that. So depending on the example that you've got, there are some examples where there is kind of a protocol you can follow. I haven't seen that for, let's say, anxiety and depression, but it would be relatively easy to work that out. So if you look at Skinner's examples of case formulations to do with depression, they're often to do with loss of reinforcement and lack of reinforcement in the new environment. the person that leaves the military, starts a new civilian job, doesn't know what to do, and feels useless. There are several pretty standard things you can do for people like that. And if you looked at, say, people with empty nest depression, the teenagers left home, they've gone to university, and the parent who is at home now has nothing to do. It's rather similar in the example of Skinner stuff, the loss of reinforcement. And the treatment protocol is rather similar. Find things for the person to do progressively, add positive reinforcement for valued activities. It may be that for depression and anxiety, you can break things down in a similar way into a small number of typologies. But there is this conflict for therapists, which is, if you have to reinvent the wheel for every single case of depression, that's rather a lot of work. And maybe it's not a good idea to do that. Maybe, having some standard treatments for dealing with depression related to transitions and losses, although the details would be different for each person, some of the protocols would be rather similar. So the simple answer is there are some standard protocols for some problems, like school refusal, but I think also it'd be relatively easy to come up with some typologies for other standard problems like depression, anxiety, drug abuse, and so on. So I think especially at the beginning of professional work, having the typologies to limit our choices and not be too confused is probably very helpful early on. And even if you're just very busy, maybe initially when you look at somebody, if you have a lot of kids with school refusal, it's probably helpful to say which of the 4 typologies we're dealing with, which of the 4 kinds of treatment protocols am I going to use? It's a good question.
So would you agree that it still seems more methodologically demanding to research treatments based on case formulation than, say, what I think I've seen more of in the literature, which is based on specific protocols? Yeah.
I think it is more difficult to do it well. With a standardized manual, let's say like behavioral activation for depression or anger management, there are manuals, there's a prescribed number of sessions. If you want to ask a question about treatment integrity and you say, was the treatment done? The usual answer in randomized controlled trials is there's a manual, and in session 5 we checked. Did they put up the picture of the dinosaur and the caveman who was scared that they're going to be eaten? And did they ask everybody, what things are you scared of? What are the physiological signs of anxiety? What are the behavioral signs? What are the cognitive examples? That's the answer to treatment integrity that people give. Now, I actually think that's a little bit of a false answer, because I wonder what is the treatment? Is the treatment the therapist following the manual, or is the treatment that the client learned relaxation training and self-exposure? I think it's the latter. But usually randomized controlled trials don't measure the patient behavior as independent variable. They measure the therapist behavior as the independent variable. I think that's a mistake. Now, so it's hard to do it with standardized manualized treatments where it should be quite easy. Think about answering the question, was the therapy delivered? If you take the easy example of, like, let's say the school refusal and the typologies of function, we can say, did they assign the child to one of the 4 typologies? We can ask a more difficult question, did they assign them to the right one? That might be a more challenging question, right? It's one thing to say, yeah, we went for number 3, but do we have a couple of experts that would agree with the therapist that that's what should have been done? So even there, having reliable data about the independent variable is largely missing, even in the simple examples. If you take the complicated examples of evaluating formulation-based treatments, it's quite tricky, because if each treatment is very idiosyncratic, there might be many components to it. If you look at the FACM model with all those diagrams of target behaviors and antecedents and consequences, do experts even agree on that? I think we don't have a standard to train people with. We should have. I mean, I always think this is interesting. I asked a colleague who was as much a philosophy person as a behavior analyst, and we had a lot of conversations about, what is a standard? And she was very good, very clear. A standard is something that is created, right? If you ask, well, what is the meter? There is a meter. It's a big lump of platinum in a vacuum in Paris. That's the meter. It was a standard that was created by scientists and so on. What's the kilogram? Same thing. There's a lump of metal in a vacuum in Paris. That is the kilogram. That is the standard. When we go on nice vacations to Paris and we walk around, you'll see in the streets, there are signs for what is a meter from the 18th century that people used to measure cloth. It looks like the meter, but it actually isn't the real meter. That's somewhere else at some scientific institution. If we want to train people to do idiosyncratic formulations accurately, the first thing we need are standards that, Renata, you and I and other experts have to create. We have to say, here's the perfect or a very good example of a formulation of these types of depression, these types of anxiety disorders. And that can be the standards that we can train people on and see if they can get the answers to how to make a formulation on a standard case. And when they've done the formulation, how to get the idiosyncratic treatment based on that. So that's the kind of research that needs to be done, but it hasn't been done. So I think the question is a good one, and it's a very hard thing to evaluate.
That's right. But that won't keep us from trying.
That's right. We can do it.
It's something that I really think about as, not only a professor, but as a course coordinator, because sometimes it feels almost like we have these great professors and it's almost as if we have as many examples of possible case formulations as we have professionals or professors teaching. So wouldn't it be good if we could have at least some variation of what would be the basic standard of a case formulation?
If I look at my own clinical training in Britain and the clinical training I've seen other people have, I think a lot of academic training is limited, because if you're lucky, you get a one-day workshop. You might get some lectures. You might have an example. You might have modeling. And maybe as you go along, maybe after lunch, you break the students up into groups. You give them cases. They write formulations. They present them and give them feedback. And you think, I hope that's okay. It seems very practical. But I think that approach to training people is limited in a number of ways. The first one is when you do the group exercises, you don't know who did what. There may be some students who didn't do anything at all, and maybe somebody who's very good at it or confident or an extrovert will, run the group and they'll present something. And maybe the other people in the group never did very much. But a more important limitation is, I think the example in an education book, it says the most common mistake that teachers make is to give one good example. And what they're talking about is general case training. Training students to do formulation on one case is just insufficient. It doesn't sample all the functions. It doesn't sample all the kinds of treatments you could use. And it doesn't sample all the problems that you might have. I think people probably need more training, and they need more varied training. And what I've seen both in Britain and the US is if I bring this up to some of my colleagues, they'll say, yes, of course you're right. But when they go on practicum, I think that's all taken care of. And I ask them, I hope you're right, but how do you know? And again, we don't check up on that. We tend to emphasize the person got 120 hours of practice. They met with their supervisor once a week and nobody got very upset. So it's probably okay. But to say the student must formulate one case well to a certain standard, we don't do that.
That's really interesting.
Yeah, imagine.
We try to do that here. I mean,
the thing it
we
takes
ask them to.
work.
Yeah, it does.
Yeah, but
so our students really have to make these formulations. They have to present them. They get corrected. So it's actually a lot of hard work. It's a 2-year course, and they have 1 year of this clinical practice with supervision, with having to present these formulations, with having to present functional analysis, specific functional analyses, and then the bigger case formulations. So we think that's a good direction, that we're demanding this from our students.
It's interesting when you look at other professionals, let's say some medical practice, you might see that somebody will say, I have reset 147 broken legs. So they'll talk about the hours, but they also talk about the number of procedures they've done as well. I think hidden inside of that is they've seen a lot of different broken legs. They've seen mostly easy ones, and I've seen some weird ones as well. But they've done a lot. And it would be interesting to think about portraying clinical psychology like that. I mean, how many formulations of different kinds should people do? How many clinical interviews should the student do to what kind of standard? I think in a year of training, I think that could be enough time, but it would take a lot of organization and a lot of feedback as well.
Definitely. I think maybe we can take another 10 minutes and just answer a couple more questions. Well, one actually isn't a question, it's more checking to see if he understood correctly. Yeah. So Alfred asks the following. A formulação comportamental é mais interessante para casos onde, durante o processo de tratamento, precisamos ter um aprofundamento nos detalhes e fatores que possam estar relacionados com a queixa do paciente. Então, ela não seria a primeira opção por ser mais trabalhosa?
I'm not. Could you say that again? I'm not quite sure what the question was, or is it just a comment?
He wants to check if he understood correctly. Okay. So he wants to make sure that the bottom line would be that it's more interesting to actually make a behavioral case formulation in cases where in case where we actually have more time and availability to go deeper and understand these details and factors, but that wouldn't necessarily be the first option because that would take a lot more time and work.
Sometimes formulations don't take very long at all. If you go look at the papers by Wolpe on behavioral interviewing, he summarizes the patient up in about 2 minutes, and he's often right. So if you give the example, he has a woman referred to him with allegedly a height phobia. But it's strange because she's been to groups of cognitive behavior therapy, she's had relaxation training, she's had medication for relaxation, and she feels more relaxed, but she still has the same problem. And so it's a mystery, right? This is obviously something is wrong here. And he talks to her and he says, "Tell me about your problem." And she says something a little strange, which when you think about height phobias, you think about people avoiding cliffs, avoiding tall buildings, avoiding looking down and falling over and fearing that they're going to fall and be injured, right? That's what you typically would expect. But when he asks the patient, "Tell me what's going on," she tells him something a little odd, which is, "Well, when I get home to my apartment and I'm up on the 20th floor of my apartment building, I look out and I look at the other buildings across the block, and I wonder, what do the people over there think about me?" Right? Now, that's the clue right there, right? Wolpe picks it up straight away. Basically, he's got the formulation at that point. So you would expect if she had a height phobia, she would go to the window, look down, and be scared and think she's going to fall out and get injured. That's not the first thing she says. She says, "I wonder about what are those other people thinking about me?" And within a few questions, it's very clear that she gets very anxious, not even when people criticize her, because they mostly don't, but she gets very anxious when she thinks about people criticizing her. And so very quickly, within 2 or 3 questions, Wolpe has the formulation in the first 5 minutes of the interview, which is, when you think about other people who might be critical of you, strangers in other buildings, the doorman in your elevator, the taxi man driving you to work, the worrying about what other people think makes you very anxious. So if you want to be diagnostic about it, it's not a height phobia, it's a social phobia, but it's a little idiosyncratic. It's the thoughts of other people being critical. And so very early on, he knows the treatment is going to be systematic desensitization, not to heights, not to people being critical of her, but for her thinking about people being critical of her. So it starts off with, I think the bottom of the hierarchy is something like the guy in the elevator. She imagines him talking to somebody and he says, "Oh, Maria's a very nice person, but sometimes her hair doesn't look that great." And then you work up a hierarchy of imagined criticism from other people. But Wolpe has the formulation within 2 to 5 minutes. So I think sometimes they don't take very long at all. I reviewed a couple of cases this morning with some services, and in both the cases we looked at, the formulations were very apparent within a couple of minutes of interviewing different clinicians. The problem is what the heck to do about it, because these were like confusing enmeshed families who were fighting with each other, with people calling emergency services and going to the emergency room and all kinds of very dramatic things. The formulation was pretty straightforward in terms of gaining attention, gaining medical attention, gaining attention from family members. That wasn't the problem. The problem is what to do about it. So I think sometimes people come up with over elaborate ideas of what is necessary for a good formulation. And it doesn't have to be hours and hours of assessment. In some cases, the person will tell you something very straightforwardly. I looked at somebody a month ago and the staff were complaining about behavioral issues in the day program. I go see the guy and say, "Hi, what's going on?" He says, "I'm bored." That's the formulation. There's nothing going on in this shitty day program, and there's no reinforcement unless he becomes aggressive and complains. Then people come rushing over. That was it. You know, so sometimes the clinical formulations can be like that. Sometimes they can be more difficult. So there are examples from Wolpe where he's like a detective and he's trying to find what are the conditioned stimuli. And sometimes people can't always tell that to you straight away. And so he has an example in the book chapter where the person gets dizzy and lightheaded and faint and worries they're going to pass out. And it takes a long time to trace that back to an event in her childhood where, as a little girl, she was taken to surgery, but her parents and the doctors didn't tell her what was going on. So she went to the hospital and they just held her down and put the nitrous oxide on her without telling her. You know, it's awful, you know. So there was a conditioning event there. It just took a long time to find it. So they're not, all the situations aren't quite like that. But there are some which are, I think, straightforward and quick. People will tell you, you know, I'm scared of going on the bus because I think I'm going to die, because I think I'm going to have a heart attack, like when my father died. You know, that's pretty close. There's probably more details to it, but that may be very close to what you need to know. What do you guys think?
Can I make one last question from
Of course.
a person on YouTube, which I thought was pretty interesting? So, Pedro, a pergunta foi: a ACT foca na análise funcional da evitação experiencial. A DBT foca na análise em cadeia, a FAP no relacionamento terapêutico. Acha que é viável unificar todas essas fórmulas de análise funcional?
What was that part? Do you think it's advisable to unify all these forms of functional analysis?
Yeah, do you think that would be possible? That's viable?
I do. I am a skeptic about all the new third wave therapies. I'm less of a skeptic about their effectiveness because ACT has got a lot of randomized controlled trials now, and there are, I think, convincing examples where ACT seems to be highly effective. So I don't think that's the important question. But very often, these third wave therapies like ACT or dialectic behavior therapy have all these interesting new techniques that come together. And they tend to be, I think, really practitioner-driven therapies. So if you look at some of the experiential treatments in ACT, it isn't that they really started with a theory of psychopathology and then developed treatments. They maybe generally had an idea that avoidance of various kinds was important, and so we're going to address covert forms of avoidance. But when you look at all the different things they're doing, you wonder what are the behavioral mechanisms behind those things. And the consequence is that we have all these different packages of different things. We have mindfulness combined with ACT, mindfulness combined with DBT, mindfulness and ACT and DBT and other things. It's extremely confusing for practitioners as consumers of research to know what the heck is going on. Which of these different procedures are the ones that are truly have the truly effective components in them? So if I look at ACT, for example, I think it's very parallel to cognitive behavior therapy. The ACT advocates talk a lot about acceptance. They talk a lot about all the covert behavior, not fighting experiential avoidance in terms of covert behavior. They talk a lot about what's allegedly going on in people's minds. And they have a lot of fun doing interesting exercises about fighting tigers and doing milk experiments and trying to change people's use of language. But then they do something else that they don't talk about very much. They do commitment. Commitment is 1960s behavior therapy. It's setting a goal, break it down into steps, and this week we're working on step number 2. So they make a lot of fuss about the new and interesting things, but very often they haven't done the component analysis or the taking the package apart to understand which parts are effective. We know from cognitive behavior therapy, from the dismantling studies that have been done, that the cognitive components are unimportant, which is very disappointing for cognitive behavior therapists because they like to do cognitive therapy all the time. And they do the B part. They just don't like to talk about it very much. But the behavioral component of CBT is equivalent to the whole package and is superior to the cognitive component. I suspect that in these third wave behavior analytic packages, that if we did component analyses of ACT and DBT, we might find rather similar results. And I think all of them would benefit from being much more analytic. So although it's fun to talk about tigers and milk experiments, what is going on? Are these forms of classical extinction? Is that what we think is going on? Because if so, we can understand the process and maybe improve on what we're doing. If you look at DBT, you see things that they're called chain analysis, but it would be better if they talked about stimulus response chains with a terminal reinforcer at the end of the problem where the attempted suicide results in negative reinforcement by reduction of aversive covert stimulation. I think if you think about chain analysis and DBT that way, as behavior analysts, we understand it better, and that may help us at least understand the treatment. But perhaps if we understand it better with behavior analytic concepts, we may be able to improve on it in some way as well. That's what Professor Sturmy thinks.
I'd love to pick your brain more about this, but maybe in the future.
Yeah, sure.
But yeah, that's great. I mean, we're still gonna have a lot of discussions with the students and study all these different approaches, and we're actually gonna start next week with studying behaviorism and then basic principles before we get into the different these different models and protocols that we have.
It's very interesting. It's very interesting to see in Skinner's book from 1953, In Science and Human Behavior. He has a whole chapter on psychotherapy, and it means Freudian lie down on the couch and talk. And he describes, what does the patient do? What's the patient behavior? What's the therapist behavior? What is the environment in that room like? What are the contingencies that they're operating in that place? And what are the behavioral mechanisms behind that particular kind of therapy? So I think that's a very good way to think about whatever the particular therapy is. And if it works, if there is something to explain, what are the behavioral mechanisms that would account for that change?
Well, thank you so much. We've taken enough of your time already, and we've read all the questions.
Okay.
Alguém tem alguma última dúvida? Quer levantar a mão, conversar com o professor? Então, espero que vocês tenham gostado. Vamos encerrar a nossa transmissão no YouTube. Então, muito obrigada, professor, por ter vindo hoje. Está disponível para tirar dúvidas, trazer suas impressões e exemplos e relatos também de pesquisas para a gente. Acho que deu muito conteúdo aí para a gente pensar ainda e discutir muito com os nossos alunos e o pessoal que está aí em casa também. Yes.
I'll use the only word of Portuguese I can reliably remember, which is obrigado. So,
obrigado.
It's a good word to know.
It's a good word to know.
Okay. Thanks very much.
Thank you so much.
Bye bye.
Bye bye. Pessoal que está no YouTube, muito obrigada. Já mandamos os links, inscrições abertas ainda para os cursos, que hoje é a primeira aula do pessoal da pós de quarta. Amanhã começa a formação em Análise Comportamental Clínica. No sábado temos a formação, a pós-graduação, tem turma sábado também, né? Então a gente tem 2 turmas diferentes começando aí da pós. Muito obrigada por ficarem com a gente até aqui, obrigada a Ellen por ficado no chat, e pessoal que está aqui na sala, vamos fazer um intervalinho de 10 minutos. Boa noite.